In this video, we're going to address the question which is very frequently asked and at the same time really baffles a lot of families and a lot of parents. Well, I'm using the example sent recently, and well, the situation is kind of quite obvious. What we are having this crooked X-ray, right, where nobody really bothered by getting any decent positioning, where the pelvis is significantly eaten away, but everything that deals with the measurements of the hips, like the femur itself, is more or less present, and you can see this typical situation. That's the head of the femur, which is way out. Well, that's the flattened angle between the head and the shaft, and the key question where everyone focuses is this. You see, this is the flat acetabulum, right? Acetabulum being the head, well, the roof over the head, and this is the developed one, well, relatively developed, at least the one which is visible, right? So the key question that comes from the mother here is quite straightforward, that the acetabulum is already dysplastic. Well, really not sure how to use the medical terms correctly, meaning that the part of acetabulum is like scraped away or flattened, right? So there is no proper acetabulum left for the head of the femur to sit under. Well, so how can the femur ever stay in the right place even after we get the base sorted otherwise? So basically the question goes like this, right? So if this is flat, then it seems that everything is already doomed, and unless somebody comes up and sort of scrapes the space for the head here, then there's no way on earth that the head is going to get inside. So that's essentially the question. And then how are we going to deal with this? So before we move any further, let's remind the picture of the normal pelvis, right? And that's where the apparent balance is present, right? So you see here you've got the head inserted properly under the roof, and then everyone feels very comfortable with this picture, saying, well, look at this great picture, this is the head, sits firmly into the roof. When we get the weight distributed from the bottom, it goes right into the pelvis, presses into, and the pelvis is a nice like head over it, so which provides the proper insertion for the legs. So that's the typical image that one would have looking at this type of picture. And then the other thing is the evolution, right? The evolution is also quite straightforward, where one would expect something like this. Wait a second. Yeah. If this is the pelvis of the 5-year-old, this is the pelvis of 11 months old, and this is the pelvis of the 9 months old, right? So here you can see that the head is not ossified, the acetabulum is not really well pronounced. 11 months old, you can see something already shaping, right? But the head is still very mildly, well, almost not there, right? And here we are. That's a 5-year-old child. So what are the basic beliefs? What are the basic beliefs? The basic beliefs are very straightforward, actually, as everything in orthopedics is full of, well, like aggressive naivety. And the belief is this, that actually as the child gets into the standing position, then the leg kind of starts digging its way into the pelvis, and by digging its way into the pelvis, eventually it develops the proper roofing. So that's one of the key myths that we actually have to address over here to understand, well, how the things are really developing. Because of course, like when you think that the leg is directly pressing against the pelvis, or if even worse, you think that actually the leg is grinding kind of, or developing its way, making its way into the static pelvis by pressing in and creating this space for itself, well, that's very naive, but it's very intuitive, one must say. And effectively, well, this is what we have to address. We have to address this particular issue. What happens with the pelvis along this transformation, and how does that work? So what is the true mechanism of this development? So, but before we do this, we have to look at that, right? So we have to look at this picture. You can see this is the 9 months old, and the development of the pelvis is a lot less pronounced. So that's just one of the hints, right? So this is 11 months old, it's a lot more pronounced, and this is the 5.5-year-old. So just watch this evolution. But you know, I think it's enough of the x-rays. Let's get into some more organized way and get some live views. Well, the first and the most important myth that I want to tackle is the one which is related to the idea that the leg develops by somehow getting the femur pushed and pressed into the bottom of the underdeveloped pelvis. See here, there is no development of the pelvis at the top, and then there is the expectation that somehow the leg is going to push its way into the pelvis. So that's the mythology, and that's kind of the question, that's the thing which is difficult to understand here, right? Because once again, these pictures, they look so intuitive, the roof covering the head of the femur. But again, I'm bringing your attention to this thing. That's the triangular appearance, right? The triangular appearance that is present, and that's the division and the opening of the pelvis. Let's have a look at the reality. So this is the newborn, okay, 1 month old, actually premature child, right? I've used his pictures before in different circumstances, and that's where we're looking at the profile of the pelvis. So this is the child who is not even remotely close to walking, right? 1.5 months old. So it's considering the fact that he was 6 weeks premature, it's pretty much like a newborn. But what can you see? Straight away, soft tissue divisions, soft tissue contour of the pelvis is very clearly present. You can see solid divisions. You know, you can clearly understand here where is the leg and where is the bum, where is the pelvis. It's very, very clearly divided. Everything is well stitched. There is no question, no doubt. You can see that as I do these moves, this is very obvious. Very obvious, this clear division, clear articulations. So soft tissue divisions, they are present straight from the beginning. So this child, even if you don't know anything about his history, you know, he's just newborn, but you can be confident that this child is going to walk, because all these divisions are present, even though if you test it, well, there's nothing to see there. And if you see here, right, I'm just giving a different perspective, but this perspective is also very important, because that's the preliminary division, right? But the other thing, which is not here yet, because, well, that's a potential here for this child to walk, but he has to undergo some transformations before he can actually get to walking and to weight transfer in the legs. And for this, we need to have a look at the bum. So what we're seeing here, well, these divisions are present, but if we look at the top, this is what I call the baby bum, the T-shape division. So where you have this T-shape with the, well, my drawings are not that great, right? Where you can see the central division. So it's just division in 2 halves. You know, it's what you are missing here so far. I'll kind of disclose the secret, right? You are missing the proper expanded development of this central triangle. And what is going to happen afterwards? As the child matures, this triangle is going to expand and expand. And as this triangle expands, then the legs are going to adjust. So effectively, this is what we want to see about the newborn, right? That these essential divisions are already present, but fundamentally, first, the bum is still a baby bum, so it's still divided just in 2 halves. It's a T-shaped division. And the number 2 is that with this, you can, well, it's another side of the same coin, that the pelvis is too flat. It doesn't have enough depth. So therefore, the primary position of the leg is being the external rotation, right? So the legs are more like frog-like open. So that's the essential starting point. Now let's have a look further down and see what's happening as the evolution at the different age. So this is the child who is 4.5 months old, and what we're seeing already that the transformation is on its way. The division is as good, actually even cleaner and clearer. But now what we can see that this triangle is clearly becoming visible, so that the contours and on top the contours and separations of the pelvis, they are much more articulated than they were in this early view. So the pelvis develops. Again, note this, it's the pelvis that develops, not the legs. We're not talking about the legs, the bones and so on. We're talking about the pelvis. But then, of course, we also know that this comes in with the changes that are characteristic to the transformations of the pelvis. So because here we can see that even with the child who is like 9 months old, there is still this, the sort of deep skeletal division of the pelvis is still very poor. But we can be pretty sure that it's going to appear, because this is already from 9 months to 11 months, and this is a very quick transformation where you can see that these separations appear. And then, well, that's eventually the evolution that is going to come to. But the key point is from here to here. And then the next point, this is the child who can stand, shifting the weight on her leg, right? And now you can really see the value of this, right? That this is the triangle, this is the center, and that's the key essential thing. That's how the thing works. You have to be able to transfer the weight on a single leg, meaning that one leg, right? One part, so that's 1/3. So that's the second part, the sacrum, which is stable, and only the third part, which is the other leg, which is moving. So this is what I call the transition from the division into halves, where it's 1 and 2, right? So the, well, kind of more the T-shaped division. Gradual evolution towards the emergence of the center. So therefore, when a child transfers the weight, it's going to be possible to have 1/3 and the second third, the side plus the center, stable, so there wouldn't be any shifts and slides upwards, right? Because when she shifts the weight here, the impact comes up, climbing upwards, right? The ground reaction comes up, and if this division is not present, what is going to happen? Well, nothing good, right? So he's going to have a tilt, she's going to have all sorts of problems on the top, but she would never be able to stay. So that's the key part. You need the central division properly established in order to be able to stand. That's the key thing. You see, that's the big roof. Acetabulum, which is going to be formed here, it's a small roof. You need to have a big roof to begin with, even to be able to discuss anything about standing as such. Conversation which zooms into a small roof when the big roof is not working, well, just nonsense. Well, this is the picture that I should have done better. Well, but that's done a couple of years ago. But you can see here that if I just show the structure of the pelvis and the structure of the pelvis here, right, the depth of the pelvis has improved, and then this is the typical picture. So now what we're observing here, this angle, if I just draw the complementary line on the other side, this is a well-developed triangulation, right? So with this well-developed triangulation, that's how she is able to stabilize herself. And this is what you can see. This is the evolution from this preliminary division already present, but the shape of the very sort of primitive T, the child develops to the next phase, where he gets from the basic T, he gets first triangle, and that's already makes it possible to get some reasonable supported weight transfer, right, without any distortions. So again, we know this child is going to stand, we know this child is going to walk. Why? We haven't seen his x-ray, but we see these soft tissue divisions. So it's obvious. Everything is there, everything is divided, so you can assume safely that when the ground reaction comes from the bottom here and travels all the way up, his bum, his transitions between the impact that comes from the ground and the contact or the transition from the pelvis to the further upper trunk, this part is not going to betray him. And again, this is the key definition. You need the big roof to begin with, and only once you have the big roof, then the rest of the good things can happen here with the small roof, with the change of the leg, and so on. So that's the central line, that's the central message, that the development of the child requires the development of this triangle, the segment, the development of the pelvis. That's the key. And then only as the pelvis develops, what happens is that this transition from this shape to this shape, okay, I can probably turn it like this to make it easier to understand, right? As the transition to this shape takes place, then effectively some other things happen. So you see over here the leg is being turned outwards. That's primitive flat pelvis. Now the next thing, as we look at this more advanced stage, now the outwards turn of the legs reduces and the inwards rotation, right, the inwards rotation, they're starting to turn more in. So that's the process that keeps going, and then actually by the time the child will be able to shift the transfer of weight on her single leg, by that time the leg already establishes the proper internal rotation in the pelvis. And that's the thing that drives these changes. That's how the change of the angle takes place in the hip. So you see, once again, over here, the early pictures, you can see that this angle is poorly developed, so it's very vertical, but correspondingly so does the pelvis. Then when we look at the next, at the more advanced child, at the further age, so what do we see? We see this. These angles have appeared, but so did that. And that's, again, as I said, that's the key point. It's a torsional adjustment. Torsional adjustment. From the flat, they develop the torsion because the pelvis expands, so this triangle increases. So that's how the leg from the flat one that it used to be developed this turn, and that's how gradually the leg is developing the double combination. On the one hand, that's the roof because the pelvis is transiting, and the other thing, this is the angle of the hip, this is the angle of the thigh. So plus the last thing that we have to tackle here is the issue of how does that roof develop. Well, that's a bit more sort of, I can't really illustrate it so clearly and so on, but I guess you have to take on board this picture that I've shown you already in my previous video, and that's really the essential one, where we talk about the fact how much greater the abdominal space becomes, and the fact is that with the proper breathing reactions, what happens? There is always some tendency for creating negative pressure, which is actually being eventually passed onto the lower abdominal compartment, And well, in short, again, it's in short, I'm not going to over elaborate on this here. In short, the development of the pelvis from this to this, right? So from not enough development, from the insufficient development of initial acetabulum to a more advanced development, happens as more as sort of the suction process that happens from the inside of the pelvis, rather than the push process that goes as the leg kind of carves its way out. And to finish this, I also want to point out that whenever the leg is working in there, there is never a direct contact. The bone doesn't touch the bone. So at the end of the day, it's the capsule that defines the stability. And unfortunately, this is what you can't see on the picture, but this is the essence of the situation. So with this relatively long thing, let me summarize the points clearly. So first of all, I'm just going to go briefly over it. Now when we see this leg, I want to highlight this big point. The big real roof is here. This is a small roof. If you don't have a big roof, there is no point even thinking or being engaged in any conversation about the small roof. That's point number one. So it's, if we put it in other words or in other format, it's the question of correspondence between the size of the pelvis and the position of the legs. If the pelvis is not sufficient there, well, there is no place to get the leg in. And again, on opposite, as the pelvis develops, and you can see even in this particular situation, in this particular child, you can still see plenty of space. You know, there's the iliac bones are still transformable. There is still space for the rotation there between the upper iliac and the sort of the ischial part. So as you can see on the others, on the other x-rays, or like on the sample x-rays there, that it's the transformation of the pelvis. So this angle is mainly formed as the product of the change of a triangle. If you don't have it, it's never going to change, right? So basically what you have to understand, that this is insufficient turn. It's the insufficient lemniscale like twist of the iliac bone. That's why the roof is not there. Second point, or third point probably, is the fact that this picture looks scary. That's what most of the people are getting freaking out from, and that's what you're being reinforced by the orthopedic doctors, that they're saying, well, you see, look at this. If you place the weight on this leg, what is obvious is going to pop out, right? Because there is no roof to protect it. Well, that's, well, a relatively, I mean, of course, if you make a child jump from the, you know, from 2 meters down, well, probably that's what's going to happen. But under regular loads, this is not the case, because effectively you have to remember there is one thing which is not on this picture, right? And this is the presence of the capsule. So the capsule is there, and the capsule is uninterrupted. So, and since the capsule is uninterrupted, and since even in a healthy person there is never a direct contact, there is no direct kind of restriction of the bone pushing against bone, well, what we're seeing that there is room here to hold. But still, I would maintain this basic thing, that don't worry about the roof. Don't worry about the big, don't worry about the small cover. Worry about the super big cover, which comes here as the triangle division of the pelvis. Worry about the lemniscale rotation of the iliacs, and then this part is going to be much less worrisome for you, because this is just the third level within. So that's more or less the cover. I hope that I've been relatively instructive in this, and well, that's it. We need to transform the pelvis, and I hope that I made you understood that there is plenty of room for inserting the leg. and getting the two positive processes in place. One, improving the overall roofing, and the second thing is you've understood the rotational process within the leg itself, the way that it's related and connected to the development of this big pelvic triangle. Alright? Thank you.